Hello, I'm Justine. I'm a flight and I'm going to be talking about ABG interpretation. This presentation was created by Leanne Jones and Chuck Skinner for the critical care paramedic class initially, and we're going to use it today for our discussion about ABG interpretation. The objectives for this particular class, we're going to analyze the alterations in acid base in the body, perform the proper ventilation and or medical management for various patient conditions in relations to acid-base balance, explain the differences between the renal and respiratory systems in acid-base balance. So why do we care about ABGs? What does it stand for? What are two important body systems that it has to do with directly? Tell us if the body is running out of compensatory mechanisms, and it gives us a guide in our patient's treatment. So the two important body systems that we're going to be thinking about whenever we think about acid-base imbalance is going to be your respiratory and your renal. You're either going to have a respiratory issue or you're going to have a metabolic issue, and that's mainly where those are housed. Your body's going to adjust to maintain a homeostasis by regulating your hydrogen ion concentration in bodily fluids, and in this case it's going to be in the blood. That's how we determine if there's a base imbalance or an excess, whether they're acidic or alkaline. The brain and the heart are going to be the most susceptible. Your body is going to be able to tolerate excess acid better than excess base, so that's something to keep in your back pocket. The way we draw to determine is via or an arse. We could do a venous one. They aren't as accurate as the arterial one. A lot of times in the hospital, the respiratory therapist will draw the ABG. As far as we're concerned and what we do, a lot of times the doctor or the RT will hand us an ABG, and we're able to plan our course of treatment based on those findings. So some important definitions as far as ABG interpretation: you need to know acid, base, acidosis, alkalosis, what pH is, compensated versus uncompensated, anions, cations, anion gap, base deficits, and base excess. So let's talk about, what are acids? Acid is a substance that gives us hydrogen ions. So an ion that donates or gives up its hydrogen in a solution. The hydrogen is an atom which gives up its electron, causing it to be unstable. Anything that's unstable, it's going to make it want to react with most substances to obtain an electron. So it's an inverse measurement of the number of hydrogen ions in a substance. So the more ions you have, the number is going to be. These are going to be what makes your pH drop. Respiratory acid is the CO2 produced from normal energy. And then you have carbonic acid. So CO2 becomes an acid when it's in water. Compounds dissolve in water. Your CO2 will be produced as long as cells are functioning, and that's what's going to form the carbonic acid. And then you have things like metabolic acids, acid and ketones. And your lactic acid is going to be whenever glucose metabolism in a low oxygen state, and the ketones are produced when fat's going to be metabolized. So what are bases? Here it says that bases are an ion that combines with hydrogen and removes them from a solution. So it's going to be a substance that's going to be desiring a proton. They can decrease the number of free hydrogen ions in a substance. You can make pH increase. The most common base is your bicarb. So your kidney is going to try to neutralize acids, and and try to reduce acid by retaining your bicarb. Have pH. The symbol used to express the concentration of hydrogen in a solution. So if you have a low pH and a high hydrogen, you're going to have acidosis. And all this is a ratio of the amount of hydrogen that's being retained or lost, a balance, if you will, and it's going to be between the base, which is your bicarb, and the acid, which is the CO2. We're going to look at a very simple way, the way that I learned how to interpret ABGs, and it breaks it down really easy, but this is just important for you to know as far as the background of it and what it's doing in the body. So your acid-base balance is the regulation of hydrogen ions. So the homeostasis concept, basically, you're trying to keep everything in proportion. You don't want excess acid, you don't want excess base. You want everything to stay how it normally is. So as fire makes smoke, metabolism makes CO2 and metabolic acids. The body's own regulators of acid and bases are going to be your lungs, your liver, your kidneys. Those are going to be things that are filtering everything out, ridding it of unwanted amounts of anything. There are disorders that cause an imbalance between acids and bases, and the body's ability to respond to that process that's taking place, which as far as if the body's compensating or not. You have various buffers, which are your primary. They act immediately. They're going to be present in the blood or tissue to take up extra hydrogen ions or release them. Some examples are your proteins and your bicarb. Like buffer system, and then you have your protein, and they're just a little bit more slow. And then as far as your respiratory system, your lungs are going to help regulate acid-base balance by eliminating or retaining carbon dioxide. So normal control of CO2 is based on the rate and depth of ventilation, but ventilation is not synonymous with oxygenation, so we have to keep those two separate. Ventilation is only going to refer to the air moving in and out of your lungs at any given time. And then if everything else is working how it should, then oxygenation happens. Proper ventilation does not ensure oxygenation, though. Let's see, so carbonic acid is CO2 plus H2O, which is going to equal your bicarb. Your pH may be regulated by altering the rate and the depth of respirations by the medulla. You could have changes in pH, which are rapid, and those typically occur within minutes. So, let's talk about the renal system. So your kidneys, the long-term regulator of acid-base balance, they're a little bit slower to respond. So if you have a change that you notice as far as a metabolic change, then it's taken a while for it to get there. A lot of times we see it respiratory first, it's a little bit quicker. Metabolic's going to take a while. It takes a while to correct as well. So just as it went wrong, it's going to take a while to go back to normal. So it may take hours or days to correct the pH. Your kidneys maintain balance by excreting ammonia, bicarb, and hydrogen. If the kidney's carbonic acid is changed to bicarb, which is a base, the formula is as follows. And ammonia is going to be helping to transport hydrogen ions outside of the body. And again, the formula follows. So let's talk about acidosis versus alkalosis. Acidosis is going to be the state of having excess hydrogen ions or a decrease of a base in a solution. So either one of those are going to cause you to have a more acidic environment. Alkalosis, removal of a hydrogen ion or an addition of bases to a solution. Exercise or serious infection will increase the production of CO2 through increased respiration in the lungs. So when oxygen is inhaled and CO2 is exhaled, the blood transports these gases to the lungs and body tissue. The body's metabolism produces acids that are buffered and then excreted by the lungs and the kidneys to maintain body fluids at a neutral pH. So disruptions in the CO2 level and the bicarb create an acid-base imbalance. When acid-base imbalances occur, the disturbances can be broadly divided into either acidosis or alkalosis, which that's what we've been discussing the entire time. So next you're going to decide if it's compensated or uncompensated. So that just means, say that there's something wrong with the direction of the acid-base imbalance. If the kidneys get involved, then it's going to be, is the body compensating for that, or are they trying to help with what's going on in the respiratory system, or vice versa? Compensated is when the body's compensatory mechanism turn the pH to normal by altering the opposing system. And then compensated is when the body has returned or maintained a normal pH by altering the opposing system. Systems may run until the imbalance cause is corrected. So here's a diagram as far as compensation. So alkalosis, which is being uncompensated because your pH is, and then on the other end of the spectrum, you've got a metabolic alkalosis, which is being compensated because your pH is closer to where it's supposed to be. So compensation is going to be in the same direction as the acid-base disturbance. All right, so now we have the oxyhemoglobin dissociation curve. That's going to be a shift to the left is caused by alkalosis. So that would be depicted as A. So low CO2, low temp, and hemoglobin holds onto the oxygen molecule, not allowing for oxygen to the. A shift to the right is caused by acidosis, so that's going to be depicted by C. And that could just be raised CO2, raised temperature. A shift to the right is going to result in a ready release of O2 from the hemoglobin molecule, which is also called the Bohr effect, B-O-H-R effect. So hyperventilatory states such as early salicylic poisoning, patients that have received massive transfusion from blood banks, and any kind of like head injury, they may have a shift as far as like a dissociation of the oxygen from hemoglobin at the tissue level. So we have to consider that whenever we're transporting patients. They may have inability to regulate their body temperature. So we're just going to have to take better care of those patients and be more in tune as to what's going on. Always ask for your ABG and see where the patient's at. This thing I just said. So if you needed to get a picture of that, you can. So base excess versus base deficit. Your base excess is the amount of acid needed to be added to create a normal pH. It's going to indicate a metabolic alkalosis, positive base level. And a base deficit is going to be the amount of base that must be added to create a normal pH. It indicates a metabolic acidosis and negative base balance. So now let's go on to the components of our ABGs. Your PO2, which is your partial pressure of arterial oxygen. A normal value is 80 to 100. And then age is going to depend. It makes a difference for infants and elderly. Infants are about 40 to 70. The elderly, it's a little bit different. It's 80 minus 1 millimeter for every year over the age of 60. Less than 40 is life-threatening at any age, and it's a predictor of potential hypoxemia. Your PaCO2, the partial pressure of arterial carbon dioxide, a normal value is 35 to 45, and these are super important to remember so that you can interpret your ABG and determine what's normal and what's abnormal. Chemical regulator of the respiratory system as far as ventilation is concerned. The metabolism affects amounts of CO2 produced, whereas change in ventilation affect how much is excreted. So here's a nice little picture. Super stick masking tape. The pH, this is what you're going to look at first typically. It's going to measure the acidity or alkalinity in the blood. A normal value is 7.35 to 7.45, however ideal is 7.40. Anything below 3.5 is acidic, anything above that is going to be alkaline. Your bicarb or your HCO3 is your hydrogen ion concentration in the plasma. The normal value of this is 22 to 26 MEQs per liter. Chemical regulator of the metabolic system. Your pulse oximetry or your SaO2 depends on the amount of hemoglobin. It's measured of the amount of oxygen bound to the hemoglobin compared with maximal capability. So the more hemoglobin, the more O2 to the tissue, it may lead you to believe that oxygenation is better than it is. A good range is about 97%. 97% of the available hemoglobin is bound with oxygen, but again, be aware of false security. So your anions and your cations, anions are going to be your negatively charged ions, and your cations are positively charged ions. Patients with severe acidosis tend to have high serum potassium levels, and then patients with severe alkalosis are going to have low serum potassium levels. So in general, a rise or fall of 0.1 in pH is associated with a corresponding fall or rise of about 0.5 serum potassium. The potassium level in serum is slightly higher than that in the plasma because the clotting process releases some potassium. Your plasma chloride and bicarb concentrations tend to move in opposing. So patients who have a metabolic alkalosis tend to have a low plasma chloride level, whereas those with the metabolic acidosis have normal or elevated chloride levels. They're going to be following each other. Increase in amount of unmeasured anions such as lactate present or bicarb. It may be very low, and chloride may be normal or even low. So it's important to note that on your patients as well. You could have an anion gap. They're going to be calculated by subtracting the major plasma ions from the major cations. So your sodium and potassium minus your HCO3, that's going to give you your gap. So there's an example with values. Normal value is 8 to 16. Anything greater than 30 indicates significant unmeasured anions. And we're going to classify those as metabolic acidosis. So the primary metabolic disturbance or anion gap formula is going to be calculated as follows. The normal range is 12 plus or minus 4. If the gap is greater than 16, metabolic acidosis regardless of pH or HCO3. So that's a diagram depicting that. Now let's talk about respiratory acidosis. That's going to be an accumulation of your CO2 greater than 45, remember. Lowering of pH to less than 7.40 results in hypoventilation. Too low VT or F on ventilator, so your tidal volume. Obstruction of ventilation. Signs and symptoms could be decreased LOC, convulsions, palpitations, warm flesh skin, and you're going to have a seesaw effect. So it's typically neuromuscular, CNS depression, cystic fibrosis, COPD, things like that. So for every 10 millimeters in the CO2, there will be an inverse change in your pH by 0.08. The results of failure to remove CO2, so a fast cause, failure to get CO2 to the lungs or out of the lungs. Anything that's slow could be things like bronchospasms, VQ mismatch, or pulmonary edema. So we always want to make sure if the patient's on a ventilator, do they have the adequate tidal volume, which the formula again for that is 6 to 10 cc's per kilogram or mils per kilogram. We have to make sure they have adequate chest rise and fall. If they're not getting the correct amount of volume, we need to fix that. And then we're only going to change our tidal volume, the rate once the tidal volume is set. So, and then here's the seesaw effect. The pH goes down, CO2 goes up. So now let's talk about respiratory alkalosis. A decrease in CO2 to less than 35. pH is greater than 7.4. Due to hyperventilation, too high tidal volume on the ventilator, least common imbalance, but it is still an imbalance. Psychogenic causes could be CNS stimulants or aspirin overdoses. And then the signs and symptoms of this could be dizziness, the carpopedal spasms, numbness to the face, any palpitations. So that's your respiratory alkalosis. And it's definitely a result of alveolar hyperventilation. And just remember your CO2 moves about 20 times faster than your O2. So if you're having anoxia, anemia, tissue hypoxia, things like that, we need to treat the patient for respiratory alkalosis and ask why. Are they anxious? Can we get that under control? Maybe we need to change their minute volume. And then also there's an example of the seesaw effect where the pH is going to go up and the CO2 is going to go down. So metabolic acidosis, the excess of acids due to decreased excretion or loss of base from the body when the HCO3 is less than 22 millimeters of mercury. Your pH is less than 7.40. Metabolic waste products. So overhydration or hypertonic saline, drug overdose or DKA. This could be our renal failure patient. They aren't filtering out as they need to. Signs and symptoms of this type of patient, flush face, Kussmaul respirations, nausea, weakness, and LOC changes. So we just have to remember for every change of 10 MEQs of bicarb, there's a change in the pH of 0.15 in the same direction. So again, some of those causes the lactic acidosis, the keto, which you're going to be seeing with your DKA patients. We need to be able to identify what those patients look like and how to treat them. We need to ask ourselves, do they have an anion gap? What was their D-stick? That might be it. Did they have a drug overdose? How can we fix that? So 50% of that can be corrected with a bolus of fluid. We need to dilute that out and help get rid of some of that and give back to what they've lost. This is going to be back. So your pH goes down, your HCO3 goes down. So then your Metabolic alkalosis is going to be the accumulation of excess base or loss of an acid from the body. Your HCO3 is going to be greater than 26 millimeters of mercury. Your pH is going to be greater than 7.45. This could be from GI losses, excessive base intake, potassium losses, liver disease, steroid use. Some signs and symptoms of these patients are going to be dizziness, tetany, QT, and remember that's going to be from probably the potassium, right? Potentially. They also have an elevator effect. So these patients could have been vomiting for the past few days if we've been NG suctioning them. And just remember the treatment's always going to be giving them some electrolytes, treat the underlying cause, but get the life-threatening situations under control prior to doing anything else. And then here's an example of the elevator effect. Both of them go up, the pH and the HCO3, or your bicarb. So here's the little seesaw dilly of your acid-base disturbances and what they're going to look like. This is good to remember if you're visual. So your respiratory acidosis, PCO2 is going to go down. Your pH is going to go toward the acidic level. So that's just one of the examples. Name your baby. So two-step process for ABG's name your baby. So we are going to look at the pH to obtain first and last name. So first name is going to be uncompensated or compensated. And we're going to look at those here in a bit. The middle name is going to be respiratory or metabolic. It can be acidic, so acidosis or alkalosis. So pH, uncompensated, and acidosis is going to lean more toward the 7.35. Uncompensated alkalosis is going to be a greater than 7.45. Always remember that your 7.40 is your midline where you want it to be. So changes in that, you're either going to have compensated acidosis or compensated alkalosis, or uncompensated. So step 2 for the process, look at the CO2 and your HCO3. Determine which one has the same name. So who's your baby's daddy? Respiratory or metabolic. So your CO2, remember the range is 35 to 45, and your HCO3 is 22 to 27. So I remember that by CO2 is not going to be, it has a 2 on it, so it's not going to be in the 20s, because why would it be that easy? So 35 to 45. And your HCO3 has a 3 in it, so it's not going to be lower, so 22 to 27. And that's just going to tell you if you're respiratory alkalosis or acidosis, or if you're metabolic, if you're in a metabolic state. So here's an example. You have your pH of 7.10. Your CO2 is 60. Your HCO is 28. So let's look at the pH. What's the baby's first name? Uncompensated acidosis. Remember 7.35 to 7.45. That's on the acidic side. All right. So is there an issue with our CO2 or our HCO3? Respiratory, right? And then you just put that together. So your uncompensated respiratory acidosis. Example 2, pH of 7.51. Remember our normal range for that, 3.5 to 4.5. Your CO2 is 44. And then your HCO3 is 35. So the first name is going to be, look at the pH, uncompensated alkalosis. And then who's the baby's daddy, CO2 or HCO3? Metabolic, right? So it's metabolic alkalosis. Example 3, 7.36, your CO2 is 55, your HCO3 is 34. Compensated acidosis based on the pH. Now, is there an issue with the CO2, HCO3? Respiratory. So you have respiratory acidosis. So let's talk about treating them now that we know how to determine which they are. So treating these for respiratory acidosis, we may need to increase our tidal volume. We might need less PEEP. We may need to increase our tidal volume. Respiratory alkalosis, we're going to reduce those, and it's going to do the same thing. We're just trying to balance with the patient. Treating metabolic acidosis, we need to consider volume replacement because they have what? They have a deficit in the amount of volume they had. So, and we always need to consider bicarb for those patients. Treating metabolic alkalosis, again, we need to replace the electrolytes that have been lost. Treat the underlying cause of the GI losses, because if they continue to have these losses, it doesn't matter how much we're replacing, they're going to continue to lose them as they go on. Cease intake of alkalotic substances. Here are some acid-base disorder mnemonics. So your metabolic acidosis, anion gap, mud pilers, and then I'll just let you kind of look through those. Very helpful though. Let's do a case study. So case study number 1, you arrive on an interfacility transfer to find an asthmatic 23-year-old female on a ventilator in the ICU. She's received multiple updrafts prior to intubation, as well as other medications to function. She's on a vent at a rate of 12, tidal volume 500, and she's 100% with 10 of PEEP. This is her ABG. So she's going to be a little bit acidic, right? The gas, and what changes would you make? And these are very common as far as we go in, we see these types of patients, and we need to be ready to change whatever needs to be changed. Of course, you can discuss it. A lot of times the doctor will be there, and they'll help you discuss, their course of treatment or what the receiving physician has suggested. But just remember the vent, you can always tweak the tidal volume, you can always change the rate, but you want to make sure you're having adequate tidal volume prior to changing your rate, right? You can continue our fluids. Okay, case study number 2. You're going to arrive to a rural facility ED to transport 62-year-old post-cardiac arrest patient. They're intubated and being bagged with 100% O2. There is not a vent available. The patient's received 2 liters of normal saline, 3 doses of epi, is on a dopamine drip at 20 micrograms per kilogram per minute. For a super low, 84/44, 70 kilos, and the lungs have rails bilaterally. They have spontaneous respiratory effort of 6 to 8. The ABG is as follows. What is it? And what ventilator settings would you set? So a lot of times hit the ABG, attempt to correct from where we're at right now. However, whenever we walk in and the patient presents like this, first of all, they have this spontaneous respiratory effort. They just received CPR. So what we're going to need to do is put them to sleep, assist them with their breathing. Right now it says that we're bagging them at 100% O2. there is not a vent available at the sending facility. They don't have a vent, which is typical. So we need to get our vent out and we can start off with some settings that are going to either correct our ABG or that are very generic. Once that patient is relaxed a little bit more, we need to worry about not dropping his blood pressure anymore, but fixing what's going on as far as his respiratory effort. And then maybe considering doing something about the lungs that have rails bilateral. All right, case study number 3. We are called to an interfacility to transport a 2-year-old near drowning, 14 kilos. Patient's intubated on the vent, tidal volume of 140. Let's see, they're 80% and 5 of PEEP. They have no spontaneous respirations. The lung sounds are rails throughout. This is their ABG, 7.49, 28, 95, 22. Any changes that we would make? All right, and then also real quick, let me go back and I have to add, let's see. We're going to talk about just real quick the BMP. Let me go ahead and pull up all the components of the BMP for you guys. We're just going to discuss it briefly since we were talking about lab interpretation. They're a little bit different for every facility that we go to. And it's just basically going to be used, it's checking the status of the person's kidneys and their electrolyte balances and things like that, as well as their blood glucose level. And from the lecture that we just talked about, it's very important that we know how their how their body is reacting to whatever process is going on. If their liver or kidneys are working, how they're handling electrolytes or electrolyte imbalances. So some things that we're going to look at are the glucose levels. Are they high? Are they low? Do they have a gap or not? And a lot of times in the basic metabolic panel, the gap may or may not be there. That may be in more of a complete metabolic panel. It's got components of electrolytes such as sodium, potassium, your carbon dioxide, and your chloride. And it should have a BUN, or blood urea, nitrogen, and creatinine, which are going to be the waste products that are filtered out by the blood, by the kidneys. I apologize. And then that's just going to show how well your kidneys are functioning. The lab values are going to be a little bit different wherever you go, depending on the facility. But typically they aren't too far off. So you're from facility to facility. So your BUN is going to be about 70 to 20. Your CO2 is 20 to 29. Creatinine is going to be 0.8 to 1.4. Your glucose is going to be 60 to 100. Serum 101 to 111. Your potassium is 3.5 to 5.5 or 3.7 to 5.2, depending on where you're at. Serum sodium 136 to 144 or 135 to 145. It's just a little bit easier to remember. And then if you remember from the lecture, all of these are going to play an important role in the transport of your electrolytes and what's following what, so that you can correct any of those that you see fit, or you'll know what the facility is attempting to correct for that patient throughout their stay. So that's all I have for you. Thank you for watching.